Welcome everyone to our monthly CME session, which is organized by Yetenaweg in collaboration with the Ethiopian Medical Association. Today we have a very interesting and timely topic on screening for cancer, and we have invited an expert on this field of medicine to take us through the rundown on this particular topic. So our guest expert today is Dr. Edom Seife of the Department of Oncology of Addis Ababa University, Anbessa Specialized Hospital. Dr. Edom Seife completed her undergraduate studies in 2012. She then served as a general practitioner at Fitche Regional Hospital and was then transferred to Addis Ababa University College of Health Sciences, where she got the opportunity to join the very first batch of clinical oncology residency training in March 2013. She has been working and training in the department for 10 years. She has also been trained in radiation oncology at the Charlotte Maxeke Academic Hospital at the University of Witwatersrand, and also in Oslo University Hospital in Oslo, Norway. Since she graduated as a clinical oncologist in 2017, she has served her institution, department, and patients tirelessly. She has a great interest in female cancers like breast and gynecologic cancers, and has spent her effort addressing these areas both in clinical practice and in multiple research projects. She won the ASCO IDEA Award in 2018 and is a co-author of the harmonized NCCN guidelines for the African Cancer Coalition on Cancer of Unknown Primary Hematology and Hemesis in 2019-2020. She won the MEPI Fellowship Scholarship from the Addis Ababa University in 2019, and she was the 5th cohort fellow until 2021. She's involved in research projects addressing female cancers and is the lead investigator of COVID and cancer and other thematic research projects at Addis Ababa University. So welcome, Dr. Edom. I just want to give a heads up to our participants that we will be sharing the link to register for this session with the aim of you getting your CME credits in the middle of the session. So following that, we will be sharing your CME credits at the end of the talk. So in the middle of the discussion, if you have any questions, you can just either make a note for yourself or later share at the chat box or ask live directly. So I invite Dr. Edom to proceed with our discussion. One thing that I would like to ask the audience is one of the things that we will be sharing later on is, as you know, Yetenaweg has many wings of medical education, research, mentorship as well. And we are looking for volunteers who are interested in contributing towards meeting those targets. So those of you who want to be involved in coordinating the mentorship programs, or coordinating the CME sessions, or other health advocacy programs, we will be sharing a link in the middle of the discussion, and then you can fill in the form so that you can be part of our group. Dr. Edom, the floor is yours, and we look forward to your discussion.
Thank you. Thank you so much, Dr. Tensai, for the kind introduction. Can I share my screen, Doctor? Yeah, so good afternoon, everyone. Sorry for the inconvenience. So now today we're gonna talk about screening for cancer, and we're gonna see why it is important and kind of see the philosophy of screening. Maybe most of you have come across some talks or lectures or some workshops regarding screening for cancer, especially cervical cancer, because that's the most commonly focused area in our country and in the Ministry of Health. But we'll see some more details regarding, I think, the philosophy of screening is very important. So we'll see, we'll have some discussion on that and see the most common cancers where screening is being applied on worldwide and also in our country. So next slide, please. So these are the pre-session questions that I would like the audience to focus on while going through the talk. So the first is what the difference between primary and secondary prevention is, what the harms of screening are, and what is the suggested age to start cervical cancer screening in Ethiopia, and what the recommended method for breast cancer screening is. So these are, I think, just kind of highlight the talk, but we'll have some more detailed discussion. Next, please. So this is going to be the outline of the talk. We're going to have some brief information about primary and secondary prevention, screening, what the characters are, the advantages and the disadvantages, whom we should screen, how we should discuss with the client, and then we'll see more detail on screening for cervical cancer and breast cancer, and finally, very briefly, on colon and lung cancer. Next, please. So the objectives of today's discussion will be on or how to understand the concept of screening, to understand screening for cervical cancer, breast cancer, and lastly, briefly about colon and lung cancer. Next, please. So why is screening a concern? Why should we worry about screening, especially screening for cancer? Because screening is actually implemented in many disease entities, but we're specifically talking about cancer, and why should it be a concern is, I think, a question that will come to all of our minds. If we see the burden of cancer, it has become a very high burden worldwide, and also in Africa, especially in sub-Saharan Africa, with the existing limited cancer care service. So having to face very advanced cancer and very limited treatment opportunity, of course, takes us to screening. If we screen patients, we get these patients in the early stages of the disease, where we can treat them with less resource, less cost, and especially save lives. So this is why it is a concern, and why it should be our concern especially. So if we see the most common cancers in Ethiopia, breast cancer and cervical cancer are, of course, the leading cancers, but also colorectal cancer is also a very common cancer. Next, please. So I think this number is a very alarming number. This is data from GloboCan IARC. It's a WHO data which is extrapolated from the only existing cancer registry, that's the Addis Ababa Cancer Registry. So you can see the projected or the extrapolated number of new cases is around 77,000, with a very high number of days. Mortality is around 51. So more than 80% of the new cases will die, and prevalent cases are also shown up here. So it's a very alarming number. Of course, this is not a kind of a real representative data, but this is the only data that exists for our population. Next, please. So when we think about cancer screening, it's a kind of a path that a person goes through throughout their life. So female, male, most of us, if we think about screening, go down this path. So Around 21 years of age, a woman especially would have to think about screening for cervical cancer. Around 40 years, a person should think about screening for breast cancer. Around 45, there should be a discussion about screening for colon cancer. Then 50 years, again, breast cancer screening, because it varies from country to country. It could also be a topic for breast cancer screening. And you can see as the age goes by, a person should be counseled or given ideas about considering screening. Next, please. So what's the difference really with primary and secondary prevention? In cancer be prevented, and if it can be prevented, which cancers can be prevented, and what are the types? So we always say that cancer is not a single entity or a single disease. It's a kind of syndrome. It's caused by different, or the etiology is multifactorial. So we can't really say that we can prevent cancer 100%, but there are specific types of cancers for whom you can offer kind of preventive care as well as a screening care. So prevention, it could be classified as primary and secondary. Primary prevention is, it focuses on, if the disease itself hasn't occurred yet, but we know that the etiology of that specific cancer type can be prevented using some prophylactic, for example, vaccination, or some other prophylactic methods can help that individual from acquiring the disease. But when we say secondary prevention, the person has acquired that etiology, or has that etiology, or has been exposed to that etiology, but we can still catch the disease in the very early stage, and try to alleviate the happening or the occurrence of a very advanced disease. So that would be secondary prevention, and that's where screening is categorized under. So screening is a secondary prevention. That person or individual has already acquired or has been exposed to the etiology and is highly likely to present with the disease or the cancer. So our aim is to catch that cancer in the very early stages and prevent its progression. So in a way, cancer is mainly aimed at reducing the mortality. So that's when we say screening is effective. Next, please. So when we talk about primary prevention, like we said, it's a kind of decreasing or somehow preventing a person, individual, from being exposed to a majorly known etiologic cause of cancer, even though it's a multifactorial or multi-causal. If we are able to prevent the most known or the most incriminated cause, then we'll be able to prevent the occurrence of that cancer to a very high level. So, for example, general recommendations as a primary prevention could be avoidance of tobacco, or being physically active, maintaining healthy weight, eating healthy diet, limiting alcohol consumption, avoiding excess sun exposure. And the most commonly known primary prevention method is vaccination, especially HPV vaccination. Next, please. But when we come to secondary prevention, where, as I said, screening is a major modality, it means detecting the disease early in the asymptomatic phase. And the positive results of these screening methods or the tests are not diagnostic, but they identify persons who warrant further evaluation. So even if we get someone to have some kind of indicative finding during the screening procedure, it doesn't mean that that person is definitely going to develop that cancer, but we have some kind of indication. So following a positive screening test, additional procedures will be done in order to rule out that cancer or some kind of pre-invasive or pre-cancerous lesion is there. So this is what we mean by screening. Next, please. So it is, screening is not an individual treatment. If we really talk about screening, it's a public health intervention. The country has to be committed, the ministry has to be committed to it, and it's to be called screening. It should be implemented in a population at risk or target population, and it's not, as I said before, it's not undertaken to diagnose a disease, but it's to identify individuals with a high risk or probability of having the disease. For example, women targeted for screening of cervical cancer, at that time of screening, they may actually feel healthy, and they may not see a need or a reason to visit the health facility. So when we say it's public health intervention, it needs education, it needs a kind of advocacy or awareness. That's when people will come seeking for a screening service. Next, please. So in order to say there is a screening program, the following or this list of criteria should be made. So the disease must have serious public health consequence, like we have shown in the first two slides. Why should this specific type of cancer be a target for screening? It should have a serious public health consequence. The disease must have a detectable preclinical stage disease, so that we'll be able to detect that lesion and act on that specific stage. The screening test must be simple, non-invasive, sensitive, specific, inexpensive, and acceptable to the target population, and treatment at the preclinical stage must favorably influence the long-term course. So whatever we do in the screening modality should be able to help the subsequent outcome. Next, please. So criteria, I have repeatedly displayed it because it's very important, because usually most professional societies come up with screening ideas, but this concept should be kept in mind, that a condition to be screened should be an important one, or it has to be public health importance. There should be an acceptable treatment for the patients with the disease. For example, if we screen and find something, there should be a treatment available for that particular finding. The facilities for diagnosis and treatment should be available. There should be, because we're calling upon people who are healthy staying at their homes, but if we don't have a service to cover that finding, then that's going to be a problem. That's going to create some anxiety. There should be a suitable test for examination. We've said that, and it should be acceptable. And the cost also should be taken into consideration. Next, please. So the main criteria is simplicity, acceptability, accuracy, cost, precision, and repeatability, sensitivity, and specificity. So all have their own implication at a health level, at a health institution level, and at a population level, especially this acceptability and simplicity for the population we are presenting the screening tests for is very important. It has to be acceptable by the population, and it has to be simple. And then at the end of the day, it has to be accurate. The finding has to be accurate with regards to sensitivity and specificity. So when we say sensitivity, it should be capable of giving positive findings when the person being screened has the disease being solved. So it's the ability of the test to pick up positive tests, positive findings, while specificity is a test should be capable of giving negative findings when a person being screened does not have the disease. So it's more related to a false positive. So when a patient or a client doesn't have the disease, the ability of this screening test to pick up the real negativity is specificity. So these things are main criteria for assessing a screening test. Next, please. So the sensitivity, like we said, to elaborate it more, is the chance that a person with cancer has a positive test. It's a chance of not missing a client who has that kind of pre-cancerous lesion, whereas specificity is a chance of a person without cancer having a negative test. So a chance where we don't label that patient as a positive while that person doesn't have the disease. So in relation with this, we have this positive predictive value and negative predictive value. We have a next slide which elaborates this a little bit more. So positive predictive value, so it's a chance that this sensitivity is truly sensitive, that test is truly sensitive, and negative predictive value is the chance that the person with a negative test does not have that cancer. So it's a true, or it is a kind of a parameter which verifies the specificity of that screening test. So a positive predictive and to a lesser extent a negative predictive value are affected by the prevalence of the disease in a screened population. So for a given sensitivity and a specificity, the higher the prevalence, the higher the positive predictive value of that specific screening test. So next, please. So there's a bit of a calculation in the middle of a screening talk. So you see that the positive predictive value on your right upper corner, the calculation, you see that there is a positive tests on the two on the column, the first column and in the first row. So true positive, there is a false positive, and then there is a false negative and a true negative. So the two right upper and left upper and right lower corners are the true positives and the true negatives, and this is where the positive predictive value and the negative predictive value focus on. So the positive predictive value, as you can see, is the true positives over the positives that were reported as positive, that is false positive plus true positive. So what we need to know is the chance or the accuracy of the test of getting the true positive. So we will have false positive, of course, but we would want this test to have a higher positive predictive value, which means that the false positives are very low. We'll get very few number of false positives. While the negative predictive value is the true negatives are really negative. So we would like to reduce the false negatives. So this focuses more on the specificity. Next, please. So these are the previous slides focused on to check if the screening test can be accepted as a screening. It's a criteria to accept the screening test. But as a whole, to accept a program for screening, it is measured in a decrease in which it brings about with regards to cause-specific mortality. So if we talk about screening for cervical cancer, in order to accept the tests that are available, for example, in the market, to accept them as a screening tests, we conduct the previous criteria like specificity, sensitivity, acceptability, cost, and others. But at the end of the day, for a country, for example, to accept that we need a cervical cancer screening program, we should know that that screening test has brought about reduction in cervical cancer specific mortality. Otherwise, there is no use in implementing such a screening program. Next, please. So what are the methods in general for screening? It could be direct, it could be palpation, it could be imaging, it could be laboratory tests. So for example, if we say direct, it could be visual observation, like on the head and neck or in the genitalia and the cervix. Palpation could include like for breast cancer, lumps, nodules, and others. Imaging could be endoscopy, X-rays, MRI, ultrasound, mammograms, and laboratory tests could be fecal occult blood tests, pap smears, and others. So we could have different methods of screening. Next, please. What are the benefits? So we've talked about the criteria and the methods and everything, but what do we gain from screening tests? It detects earlier cancer in the earlier and more treatable stages. We've said that, and it's anticipated to reduce the mortality from cancer, and this is established through different surveillance studies they've implemented, especially the US and some European countries are very strong in screening programs, especially the US. So most data come from these countries, which established screening tests to be beneficial with regards to decrement or reduction of mortality. And the other benefit is prevention of occurrence of cancer by identifying and removing the precursor lesions. At the end of the day, it's also to reduce the mortality. So for example, endoscopic screening for colorectal cancer or pap smear test for cervical cancer could be cited as examples. Next, please. Yeah. So for different cancers, especially colon and lung cancer, all-cause mortality was found to be reduced due to screening. For example, for breast cancer, all-cause mortality wasn't found to be decreased due to breast cancer screening only. So it's only the odds of dying from breast cancer that was found to be decreased, but all-cause mortality, for example, wasn't found to be reduced. We'll see specifically when we go to that topic. But the screening test for breast, for example, reduce the odds of dying from breast cancer. Next, please. But it has disadvantages. Screening is not all about advantage. It has disadvantages. It has harms. One of the disadvantages is possibility of serious test-related complications, which may be immediate, like perforation with colonoscopy, or delayed, like potential carcinogenesis from radiation exposure. Or there could be false positive screening test result, which may cause anxiety, and it may lead to additional invasive diagnostic procedures. We'll talk more about this on the next subsequent slides. Next, please. So, for example, we commonly use PSA, or it is recommended to do PSA tests for breast cancer, but they have false positive rates of 5 to 10%. So imagine a patient who has a PSA elevated, and if they turn out to be one of the cases with false positive result, then obviously with an elevated PSA, nobody's going to sit at home. They're going to seek for a biopsy, MRI, and so many things. So this will create anxiety, unnecessary investigations, and all these things. And there will be follow-up invasive diagnostic procedures and so many costs and anxiety to the patient. So this is one of the disadvantages. Next, please. The other most common cited disadvantage of screening is overdiagnosis. It occurs when screening procedures detect cancers that would never have become clinically apparent in the absence of screening. So this is the most common argument that is raised, especially for prostate cancer screening. And there could be, because prostate cancer is known to be very indolent, and clients whose prostates or whose PSA tests were found to be high, and they were diagnosed to have an early prostate cancer, they will be subjected to biopsy and then surgery or radiotherapy, which will result in impotence, urinary incontinence. All these side effects from the treatments will result. But probably if we left these clients alone and if we didn't have a screening, these patients might not have had this advanced disease at the end of the day. They could have lived without any symptoms from the prostate cancer that was picked up during the screening process. So this is overdiagnosis. Some lesions or some precancerous lesions might take a very long time to grow, to become, subject the patient to, or the client to symptoms. So we just intervene for nothing. So this is overdiagnosis. Next, please. So it's a major source of harms, and some of the harms of overdiagnosis may be mitigated by strategies such as active surveillance. So instead of treating these patients, we could put them on active surveillance. So active surveillance is a terminology which is used to follow patients intensively with investigations, and we have to make sure that clients are compliant to the follow-up regime or schedule. But this is implemented, for example, in prostate cancer. Next, please. There could also be bias in screening. So sometimes we may interpret that that screening modality is bringing about, decrement in mortality, but really it's not causing that reduction in mortality, because what's the most commonly raised argument is that clients who come to clinics, first of all, have very early disease, which by itself is amenable to treatment, and these clients are long-term survivals. Additionally, mostly clients who come to health institutions seeking screening are those who lead a kind of healthy lifestyle, and they are deemed to live long. So this is raised as one of the possible bias, and also there are what we call lead time bias, because for example, if we quote a client 40 years old with early breast cancer, we treated that patient, she has no cancer, she lives for maybe 20 years more, and no recurrence, nothing related to the breast cancer. So these clients are automatically included into breast cancer outcome cohort, for example. So when we're calculating, survival of breast cancer, these long-term survivors contribute to the very long survival of breast cancer patients. So it kind of brings about this lead time bias, where we, think that breast cancer patients are surviving very long, but really this long survival was contributed from these clients whose diseases were caught very early during the progress. Next, please. Next, please. I think we've gone through this. So you see that this long-term survival, like 5-year survival rates, are largely due to the earlier diagnosis and sometimes due to overdiagnosis. And reduction in incidence also could be due to this lead time bias. So we detect very small number of late diseases. Next, please. I think we've already covered this. Next, please. So we can see an example where this US surveillance data have shown a 10-year relative survival rate of more than 100% in patients with early stage prostate, thyroid, and breast cancer, and also ductal carcinoma in situ. And these tumors are frequently diagnosed by screening, and this could lead to a kind of bias where we think that treatment for breast cancer is increasing the survival. So it could create some kind of confusion. Next, please. So some of the things we need to note is, in general, overdiagnosis is more common in older individuals and those with otherwise limited life expectancy, since the slowly growing lesions associated with overdiagnosed cancers have less time to become clinically apparent in such persons. Remember, we've said that overdiagnosis is all about those cancers which would have not become clinically symptomatic if we didn't do anything. So if we caught a person very old, like 70 years, with a screening program to have breast cancer, patients of this age might die of other competing comorbidities. So if we didn't do anything for these patients, also they wouldn't have any complications from the early disease. So mostly screening programs exclude old clients from such screening schedules, because it could lead to overdiagnosis. So it's better to leave out these clients from screening programs. That's the kind of the connotation of this slide. Next, please. So in conclusion, we have to balance the benefits and the harms of a screening. We have so many screening programs, especially, like I said, in US, in the Western world, And it is more favorable for higher risk individuals, since they have a greater probability of benefiting from the screening, while typically having a small similar kind of or likelihood of experiencing the harm. So screening should be tailored more to patients or clients with very high risk. Next, please. So whom should we screen? At the end of the day, we have to know who should be the target of screening. This is mostly high risk population. Cancer risk increases, as we know, with age, but some individuals have higher risks. So this could be those with a strong family history, those who have been exposed to environmental or occupational carcinogenesis like asbestos, uranium miners, personal behaviors like smoking, alcohol consumption, and those who have been treated with radiation, but especially nowadays, due to the availability of radiotherapy. For example, in our center, we're treating so many pediatric patients with radiation therapy. So these patients should be enrolled in screening programs. Next, please. Next, please. Yeah. So who decides? I mean, is it the Ministry of Health? Is it the government who decides on the screening or the need to be screened? So the general consensus is no. It should be based on discussion, and the clients should believe and be convinced that they need to be screened. So they increasingly, these guidelines mention the importance of individuals making informed decisions, and there should be unbiased and balanced information about the potential benefits and also about the harms of cancer prevention and screening. So it should be bilateral, especially the patients or the clients should be informed, and they should decide whether they need to be screened or not. Next, please. So there are three components of shared decision making. The provider shares options, the patient shares the preferences, and then the provider assists with the recording and implementation of the patient's preferences. So this should be the way a client should receive screening. Next, please. And there are there should be patient decision aids. We should show them some pictures, informations, so that they could, accept the test and implement it. And we could have videos, websites, and others, depending on the educational and literacy level. Next, please. So now we'll come to screening for cervical cancer. I think after some few slides, we'll revise the questions. This is going to cover the bulk of our talk or discussion. So there are some myths and some evidences. So incidence rates have stabilized in the most recent decade, especially in European countries. And the pace of decline in the death rate has also decreased by 0.8% per year. And it is mainly attributed to screening by pap test. Next, please. So you can see this graph depicts how cervical cancer is expected to reduce. The incidence of cervical cancer is expected to reduce by implementation of one of the preventive mechanisms we've mentioned, primary prevention, that is vaccination. So you see vaccination programs would result in a very significant reduction in cervical cancer incidence, but actually after a very long time. So if we stick to the vaccination program we have now, we expect that the incidence of cervical cancer will reduce in a very significant amount in probably in 30 or 40 years time. Next, please. So these are the data from a very, European countries who have implemented screening, prevention or vaccination programs very early during like 20, 30 years ago. And some of them are actually extrapolations. So for cervical cancer screening, WHO recommends 3 types: HPV testing, pap smear, and VIA at the bottom of the screening modalities. What's a very important thing we have to note about cervical cancer is precancerous lesions take many years to develop, and repeated screening is recommended for every woman above age 30. That's the WHO recommendation. Next, please. So these screening tests, they are capable of identifying a woman with a high probability of having cervical intraepithelial neoplasia, CIN, or squamous intraepithelial lesions, or preclinical invasive cancers. These are the lesions which have a higher probability of evolving into cancer. So we expect our screening tests to pick up these lesions. Next, please. So the objective of cervical cancer screening, like I said, is to pick up these very high-risk lesions, CIN2 and 3. So we expect the modality we choose to be able to pick up these lesions with higher sensitivity and specificity. And of course, the effectiveness is based on the reduction in mortality. Next, please. So these CIN lesions, especially the early ones, CIN1 and CIN2, not all of them progress to invasive cancers. So many, the mild and moderate lesions will regress, while we expect more than 80% of the CIN3 to progress into precancerous lesions, or to invasive cancer. Next, please. So what's the best advantage of cervical cancer natural progression is that it takes a very long time, like we've said earlier, to progress into an invasive disease, and it gives us an opportunity to screen and to detect these lesions during this time, because the progression from pre-invasive lesion to invasive lesions is very long. It might take up to 20 years. Next, please. So what's the etiology? As we all know, is HPV. That's why one of the primary preventive mechanisms is targeted at preventing the acquisition of this HPV. This oncogenic virus, and it's the etiologic agent of cervical cancer in more than 90% of the cases. So other risk factors contribute very little to the occurrence of cervical cancer. That's why HPV vaccination and eradication has been the major target for the cervical cancer elimination. And it's obviously, as we all know, transmitted by sexual contact. And sexually inactive women rarely develop cervical cancer, while sexual activity at a very early age and multiple sexual partners is a strong risk factor. Nearly all, like we've said, more than 90% have HPV infection, those who have cervical cancer. Next, please. Like we have said, approximately 15 cancer-associated high-risk carcinogenic HPV types have been identified, but HPV 16 and 18 are known to be the major cause. But some studies, very large studies which have been conducted in our country, some of them in cohort studies, have shown that other variants of HPV are also more commonly associated with cervical cancer than it is reported in international evidences. Next, please. So although the mortality increases with age, the prevalence of CIN is highest among women in their 20s and 30s. So this is an opportunity to pick these lesions in the pre-invasive status. And we have said that 70% of these CIN1 and others, CIN2, the early ones, regress, while about 10 to 20% of women with CIN3 lesions will progress to invasive cancer. Next, please. So the other test is pap smear test. It's a pathology test, and it has never been examined in randomized controlled trials. And but there are so many observational studies which support its effectiveness in reducing mortality. That's a major goal. So mainly these European countries, have seen the mortality rate reduced due to pap smear tests around 80% for Iceland, and we can see that 50 to 34% in Finland and Sweden. Next, please. So this is how a pap smear is taken. I think most of us almost have been exposed to this kind of tests. We've seen during our attachments, or we've seen it being done. Next, please. So the sensitivity is said to be 70 to 80% with a specificity of 95%, which is good. And one important factor in the accuracy of pap test is in order to have a good test, we have to have an adequate specimen and also an adequate technician. I mean, a trained technician and a pathologist. So this is kind of the requirement to really say that that test was done in a good manner. Next, please. So this regular pap screening decreases cervical cancer incidence and mortality by at least 80%. We've seen that. What are the harms? Still, like we've said, it could pick up some low-grade lesions, and especially young female patients could be led to unnecessary subsequent investigations, procedures, and treatments. So what is the magnitude of this overdiagnosis? Additional diagnostic test was done in up to 50% of women undergoing regular pap testing, and approximately 5% were done for these low-grade lesions. Next, please. So we can see it's very significant. The HPV tests, so we've seen that HPV is the main causative factor. So HPV tests could be a very important screening test other than targeting HPV as a primary prevention. So we have DNA tests, RNA tests, rapid tests, and also PCR tests. So technology has given us so many options to test for HPV, and it is approved to use in two contexts mainly. One is as a second or a triage test, and the other is with co-testing. So it could be either with pap smear or with BIA. So it is used in one of these two situations. Next, please. So screening with HPV DNA or RNA test detects high-grade cervical dysplasia as a precursor lesion, and additional clinical trials show that HPV testing is superior to other cervical cancer screening tests. So in 2014 in US, it has been accepted as a primary screening test for cervical cancer. Next, please. What are the harms? It identifies numerous infections that will not lead to cervical cancer, just like we said, overdiagnosis. And this is especially true in women younger than 30, because these clients might clear the infections throughout their lifetime. What is the magnitude? Around 86.7% of women with a positive HPV test did not develop cervical cancer or related pre-malignant disease. So co-testing may be advised in such situations. Next, please. So co-testing, which brings us to the next topic. This is co-testing is using two tests, especially most commonly implemented is pap and HPV DNA test. And it reduces the incidence of cervical cancer, also reduces this overdiagnosis. Next, please. So what is the harms of co-testing? It's associated with more false positives than in pap test alone. And abnormal test results obviously could lead to testing for further investigations, but the magnitude is very less when compared to using either HPV test alone or pap test alone. So using the co-test actually decreases what we say, the risk of overdiagnosis. Next, please. And the final one is visual methods. The visual method actually is implemented, I think, in very low resource limited areas like ours. Actually, this is a first-line test or screening test implemented in Ethiopia. It could be either with acetic acid or Lugol's iodine, and they are identified by inspection of the cervix with a magnification after application of either acetic or Lugol's iodine. So if we implement acetic acid, then it will turn white, and if we put on Lugol's iodine, it will be brown. Next, please. Yeah, we can go to the picture. Next, please. So you can see VIA with acetic acid and with Lugol's iodine and how it appears. This is a. So yeah, you can go to the next slide. So the advantage, it's relatively simple. It can be taught to nurses, midwives, and other health workers. The assessment is immediate, and if we need to treat, we can treat immediately, just on the spot. They are less costly, and results are evident immediately, like we said, and we don't need to do repeated tests, and they could be kind of screen and test approach. Next, please. But the disadvantage, as we see, is a low positive predictive value. It's dependent on the observer, and it cannot be relied on in postmenopausal women because the transformation zone is often inside, and you cannot see it. And there is also no record of the test, so we cannot keep a record of the test. If we think that test was wrong, then there's no way of verifying whether it was done correctly or not. Next, please. So this is the guideline. This is 2021 guideline in Ethiopia. VIA test is the first line test. It's widely available in the country. VIA negative, we rescreen after 5 years. VIA positive, we go to either cryotherapy or we go to LEAP. Suspicious, we refer for appropriate diagnostic and treatment if we suspect cancer from the outset, not a precancerous lesion. Next, please. So also in our country, we are implementing this primary prevention with Gardasil 9 inserting vaccination, HPV vaccination for girls, not boys, actually at this time. So age is 9 to 13. And then age from 30, we start screening and we follow these patients. Next, please. So this VIA was combined screening with was implemented in Ethiopia in collaboration with Ministry of Health and Pathfinder, and it was introduced in 2009 and still is the first line approach in many health institutions. More than 1,000 health institutions are practicing this VIA cervical cancer screening. Next, please. So the age group is starting 30, unless they are HIV positive. HIV positive patients, they could start at age 25 because we know that the chance of acquiring HPV in concordance with HIV is very high. So they are very high risk women, so we can start at age 25. Patients who have hysterectomy are not candidates, of course, because this testing is implemented on the cervix. And we should start screening, especially for HIV, at the time of HIV diagnosis. Next, please. HPV DNA testing, especially in our country, is not like a primary test, but it's implemented in some institutions in combination with or as a co-testing with VIA. Also, PAP test is also not a first-line testing, but also could be used as a co-testing, and not all centers have pathologists to conduct these tests. Next, please. So HPV DNA test, like we've said in Ethiopia, if negative, we rescreen in 5 years. If positive, we do VIA. So we have said it's either co-testing or a triage test. And then the VIA also follows the same as the previous one. Next, please. So if there are questions, or if we could address some of the pre-session questions, we can go forward with that. I don't know, we are on time. I remain with few slides concerning breast cancer screening. I think the organizers could comment.
You can wrap up You can wrap up your presentation, including the breast cancer screening, and then after that, we may go through the pre-lecture questions, and then the audience can share their questions as well.
Sure. Okay, so we can go to the next slide. So we'll go quickly through the screening for breast cancer, colon and lung cancer. All these screening programs are not implemented in Ethiopia. They are of a kind of intellectual interest and probably will happen in the coming few years. So the majority of breast cancer, especially in the US, are diagnosed as a result of screening. And findings suggest that screening mammography both reduces the odds of dying of breast cancer and facilitates the use of early treatment. Next, please. So it is said that the breast cancer mortality has reduced since 1980s, and but it is the evidences show that the reduction in mortality cannot purely be attributed to the use of screening, but also rather to the advancement in breast cancer treatment, because we have evidenced that breast cancer treatment has really become very important and very influential to the mortality and improvement in survival of breast cancer patients. So improvement in overall survival cannot solely be attributed to the presence of screening. Next, please. So what are the major factors to determine risk category based on a patient's history? So when we talk about screening, like we have said, the risk of the patient is very important. So for breast cancer, there is either an average moderate risk or a high risk patient or client. So who are very high risk, who is moderate risk? There is actually a model, glial model. It's available online. I have included in the presentation, so anyone can check on that. But like we know, we can't really apply models and schemes that are implemented in Western world directly to our situation, but we can somehow infer to them. So, but these are very important risk factors like personal history of breast, ovarian, tubal, or peritoneal cancer, family history, known carrier of any mutation, mammographic breast density, previous breast biopsy, age at menarche and menopause, and also age at first birth, number of pregnancies, and radiotherapy to the chest, especially age between 10 and 30, like I've said, because we are using this modality now more frequently. These are very important risk factors. Next, please. Yeah, I've talked about this. Next. So women who doesn't have none of these risk factors are considered as average risk, but women who have one of these risk factors could be considered as high risk. So average risk women have a lifetime risk of being diagnosed with breast cancer of around 12%. Again, this is the data from US. And it is important to remind patients that this is a risk of being diagnosed, not a risk of dying from breast cancer. Next, please. So if a patient of a client has a high-risk family history, all individuals at risk of hereditary breast cancer and ovarian cancer syndromes should be identified. And actually, if we have the facility, refer to a special screening center. If not, we should advise these patients to have frequent intensive screening as well as some prophylactic treatment, like they could undergo bilateral oophorectomy, mastectomy, or chemoprophylaxis, like with tamoxifen. So we don't have any standard recommendations in Ethiopia, but in other parts of the world, there are recommendations in clinics dedicated specifically for this purpose. Next, please. So we should emphasize the value of appropriate screening and enhanced, screening for this high-risk population. Next, please. These are the high-risk: 1 case of breast cancer, less than 40 years old, in a first or second degree relative, 1 first or second degree relative with breast cancer or ovarian cancer, 2 or more cases of breast cancer in first or second degree relatives, a first or second degree relative with the breast cancer less than 50 years old, 3 cases of breast and ovarian cancer, at least 1 ovarian, 2 cases of ovarian in the first degree relative. So 1 case of male breast cancer also is a very high risk situation for that particular client. Next, please. So what are the methods? It could be mammography, clinical breast examination, or breast self-examination, currently labeled as breast self-awareness. Next, please. So mammography is the standard of screening for breast cancer. It's a radiologic technique, it uses X-ray films. Other radiologic techniques like ultrasound, MRI, and others are actually reserved for high-risk population. And it is mammography is estimated to reduce the odds of dying by 20%. Next, please. So this is how mammography is done. Next, please. How about breast examination by clinician, like what we call clinical breast examination? WHO doesn't recommend as the only screening method. If we have mammography, that's the best. But if we don't have clinical breast examination, plus or minus ultrasound is the best way to conduct breast, cancer screening. But it couldn't be labeled as like a standard screening program. How about educating women about breasts or breast self-examination? That used to be called breast self-examination, but currently it's called breast self-awareness because we need to aware women about their breasts and what's normal and abnormal, but not leave it to them to decide whether to decide whether they have something wrong or not. So they should be aware of their breasts, what's normal or not normal. And whenever they see something that's not normal, they should visit the health institution and clinical breast examination should be done. Next, please. So in locations where imaging modalities for breast cancer and screening are not available, CBE or clinical breast examination will be the screening modality. So the WHO states that CBE may not be appropriate screening, but in low and resource settings with health systems, that would be the only way out. So it's not absolutely not contraindicated, but it will not be the best way to screen women. Next, please. So screening average risk individuals, 40, 50, it's still controversial. Considering our population, maybe the life expectancy of the population is very low. Plus, we're seeing more patients with younger age and breast cancer. We may be tempted to start at 40. For those who choose to undergo screening, the interval for screening would be every 1 to 2 years, depending on the patient preference, but 2 years would be enough unless they have high risk. Next, please. So American Cancer Society, again, recommends 45, but they also could do 55. So we have to consider our situation. Moderate risk means first degree family history, but no gene mutation, but the follow-up is similar to the average risk. Next, please. So what's the situation in Ethiopia? There are so many initiatives currently going on. Our hospital, Black Line Hospital, in collaboration with Churchill Health Center and Martin Luther University in Halle, Germany, has a project funded by Else Corner, and we have started screening program in the Churchill Health Center. It has been almost a year, and we have screened around 1,000 women. Pink Lotus, one of the NGOs which works on advocacy, is also conducting some screening campaign every summer here and now. But we don't have a kind of organized screening program that's implemented in Ethiopia until now. Next, please. So we could either go through colon and lung cancer screening, or we could stop here. If you recommend I go through it, we can, but I think it's going to be a lot. We have maybe 10 or...
Okay, maybe since there are a lot of questions that are coming through, we can maybe handle those questions, and if time allows us, then we can go through the rest of the slides. So I'll go through the raised questions. So there are typed in questions as well as there are people who want to talk.
The audiences want to continue. If that is okay, would that be okay? The attendees, everybody's keep asking. Please continue. I think they want to learn.
All right.
Dr. Edom, would that be okay?
Yes, sure. So we can, then we will briefly talk about colon cancer screening and finally lung cancer screening. So colon cancer, as we have seen on the epidemiology on the first slide, it's a kind of the third ranking tumor in our situation. But the number is very small actually, although it's third ranking, but the highest number is occupied by breast and cervical. But the rest of the world, as I said, is implementing colon cancer screening methods as well. There are different methods, radiologic, laboratory, and others, also blood sample, but not standardized. So we'll focus on more commonly used methods. The first one is the fecal immunochemical test, or FIT, for blood. It directly measures hemoglobin in the stool, while this guaiac-based fecal local blood test, it identifies hemoglobin by turning guaiac reagent impregnated paper blue. So it's a kind of reagent or toolkit testing. The difference between the two, more or less, the outcome is said to be the same, but this guaiac test requires a repeated stool, they need to take different samples, while for the first one, we need to take only one sample. Next, please. The other most commonly used screening test for colon is endoscopic evaluation. Obviously, we know it directly visualizes adenomatous polyps and colorectal cancer within the field of vision of the endoscope. This provides a potential to remove polyps, so it could also be used as a therapy. And the lesions could be adenomas, carcinomas, or either. It's an invasive procedure, very difficult to handle by some patients, especially. So it needs to consult with the patients. Like I've said, we need to counsel and discuss with the patient the benefits, harms, and the procedure as well should be discussed thoroughly before we decide to do it. Next, please. The other is computed or CT colonography as imaging. Or used to be called virtual colonoscopy. It involves obtaining multiple thin slice CT data, and we see the image and see the possible lesions. So it also requires expertise in radiology. Next, please. So like I've said, we need to discuss the screening test with the patients, and after determining that the patient is at an average risk of colorectal cancer, shared decision-making process will be there, and it is recommended to initiate colonic cancer screening at age 45. This is also based on US data, and if we choose colonoscopy, it's done every 10 years. This is for average risk population. If we choose this the fecal immunology test, it's going to be done annually on a single sample. Next, please. If we choose stool DNA testing, it's going to be done every 1 to 3 years. If we choose CTC, every 5 years for patients unable or unwilling to have colonoscopy. And we have to note that if any of these tests, especially the non-endoscopy tests, turn out to be positive, colonoscopy must definitely be done. So we have to advise patients, if either their fecal test or CTC, this CT colonography test, or whichever test becomes positive, then we have to go to colonoscopy. Next, please. So I think regarding colonic cancer screening, we don't have nothing in our country. Like I've said, it's third ranking, but it's not high in number. But we need to identify people who may have high risk and actually offer individualized screening, at least for the current time. And the most commonly used utilized colonoscopy, I think regarding the invasiveness of the procedure, is kindly not more accepted by clients, but we need to advise that there are other options. We have had one thematic study that has been done regarding CT colonography or virtual CT. We haven't seen the results of, it hasn't been published yet as to my information, but I think after we see the results of that paper, we may decide to use also CT as one option of screening for such patients. The last topic will be screening for lung cancer. So it is designed for, especially for patients who currently smoke or have history of smoking. So most of all, they should be advised, that is the primary prevention, as we have said earlier, but screening would be using low-dose CT scan. Low-dose CT scan has harms, which includes false positive tests, but with regards to the exposure, with the dose exposure, it's like it says, it's low dose, it's supposed to expose a patient to a very low dose, but still there is some dosage that's being delivered to the patient. So it could lead to overdiagnosis, or it could be the harms of exposure to some radiation, or it could result in anxiety. Next, please. So which group of patients are indicated? Adults aged 50 to 80 who are at high risk of developing lung cancer. These are patients who, or clients who've had 20-year smoking history and are either current smokers or former smokers, having quit within the past 15 years. And for this group of clients, we need to offer them annual screening with low-dose CT. It should be discontinued if the client has not smoked before 15 years. And it is advised in accordance with this US Preventive Service Task Force, that is in 2021. It's revised in 2021. Next, please. The rationale is that especially two large randomized trials have shown screening with low-dose CT reduces lung cancer mortality, especially in patients with risk due to current or past smoking. Screening modalities that are not recommended are just X-ray, CT, sputum. They are not effective, so we shouldn't use either of these, or normal CT scan cannot be used for screening purposes. Next, please. What's happening in Ethiopia? There is a current initiative again. It's a kind of project. It is called Lung Cancer Diagnosis and Control Project. It's a new 3-year project, 2020 to 2023, implemented in these places mentioned like Dupti, Awash, and Afar, Oromia, and Amara regions. Through the support of this Bristol Myers Squibb Foundation, these areas have been targeted due to the high burden of tuberculosis, industrial parks, and biomass utilization. And it's implemented by the partnership of the Ministry of Health, Matthias Wundu, Ethiopia Cancer Society, and Addis Ababa University Black Line Specialized Hospital lung unit, and also our center. What's special about lung cancer in Ethiopia could be that we face, the smoking prevalence is very low, but we see a lot of mothers who reside in the urban areas of the country come with lung cancer, and it's expected that maybe indoor smoke exposure could have a higher risk. So this project is already started, and they are screening people with smoking history. Maybe you could, I think it's available online. You could go through the indications and which group of clients they enroll, but they are utilizing low-dose CT to screen for lung cancer. So this is all about kind of highlight of screening for cancer. Thank you so much for the attention and for the opportunity. And if there are questions, we could, address them briefly.
Thank you, Dr. Edom. That was an excellent presentation. I think the attendees and the participants also agree. They've been texting us in the chat, stating the same. If there are people who want to ask questions directly, you raise your hand and we'll let you come on the stage to ask the questions. But I think there were some questions already sent in the chat box and then the question and answer. Dr. Tensai, you can go ahead and start the question and answer session. Dr. Tensai, are you there?
Yes. So maybe we can go through the questions in groups because there are a lot of them.
Okay.
So the first, Dr. Edom, do you want me to give you the questions in 4s and 5s?
Yeah, I think that's better so that we can address them.
Yeah. So the first question is on how frequently is the recommendation for pap smear screening? I think that was already discussed, but you can answer it again. And the second is, do you recommend screening for hepatitis B and C as a component of screening for liver cancer? The third is, do you think that HPV DNA testing for high-risk variants could be used as the sole screening method for cervical cancer in settings where cost is not an issue? We have a fourth question on breast cancer screening. Is there any age cutoff to use mammography or breast ultrasound? Maybe we can answer those and then we can proceed to the others.
Okay. So maybe start from the last one. Age cutoff for mammography, that's a very common question to be asked because, so like I've said, there is what we call the individual screening or population screening. So for an individual who needs to be evaluated by mammography, aside the technical, the radiological contraindications to offer mammography for example, for a younger age woman who has a dense breast, we can still do it, but that should be individual. If we talk about screening in general as a population, mammography is the standard of method, and we offer it. Like I've said, it differs from guideline to guideline, 40, some say 50, sometimes some say 45. Depending on our situation, we may start at 40. There's no agreement yet, but I think it's going that way. We've had some task force meetings. So it could be 40, we're not sure, but for now, 40, 45, 50, depends, different guidelines. So when we talk about population, but for an individual, as long as the technique allows, we can do mammography for the patients, but mostly young age women have very dense breast and it's very difficult to interpret findings from mammogram. So we recommend usually breast ultrasound. HPV DNA for high-risk variants, yes. And like I've said, in US especially now, they are using HPV testing as a sole method of screening. But for us, due to the different constraints, economic costs and whatever we have, we still rely on co-testing, VIA followed by HPV as a screening followed by VIA, depends on the availability even. And also there has to be consideration about the variants that are common in our country. I've been mentioning that there are some large cohort studies which have shown that the known commonly incriminated HPV strains are not actually common in our society. So we need to conduct, or we need to gather more data regarding this issue, but it could be used. Hepatitis B and C for hepatocellular cancer screening, still there is, as far as my knowledge is concerned, there is no strong evidence. So like we say, the screening, it has to focus on the prevalence of the disease. If you are still, I'm talking about population-based screening. So if it is a major public health concern, and if that test could really determine or bring, the pre-invasive or the precancerous lesions, or if it's highly sensitive, specific in others. So Hep B and C for HCC, as far as I know, it's not a recommendation, but I think we can check, and we can look up on that. Pap smear testing. Nowadays, it's a kind of not like a first line recommendation to do pap testing. HPV, like in worldwide, it's HPV, but still the screening, especially for the different CIN levels, differs. So if you have CIN1, CIN2, CIN3, there are different recommendations. For example, if you have CIN1, it could be every two, I guess, or every 3 years. CIN3 would be followed by additional tests. We have to have additional confirmatory tests, because these are the lesions which are known to progress to precancerous lesions in more than 20% of the cases. So for this group of clients who have CIN3, we need to have additional tests being done. But for the rest, every 2-3 years, we can do pap smear testing. Yeah.
Okay, thank you. There were 2 people who raised their hand during your presentation for questions. The first is Dr. Tigist Abate, and then Dr. Tigist Gammachu. So one after the other, can you please unmute yourselves and ask your questions? First, Dr. Tigist Adane.
You can still raise your hands, and I'll allow you to come on stage. I don't see anyone raising their hands. Otherwise, Dr. Tensei, you can continue with the, okay, I see Dr. Abdul Kader. I will allow you to talk, so you are on the stage. Unmute yourself and.
Hello, can you hear me?
Yes, we can hear you.
Okay, thank you. It's a good presentation. I have one question. Is there any age limit for pap smear screening in our setup, or can we screen women on the age above 55 for pap smear? Thank you.
Thank you, Abdul Kader. Yes, Dr. Edom, you can go ahead.
Oh, okay, yeah. So like we have mentioned, this pap smear test, the most common, limitation, like we've said, is the sample. Usually sample is taken from the vagina or this fornices. So the sample should be taken from the cervical os. So like I've mentioned, especially like you also said, women above age 55 or older women, postmenopausal women in general, they are the sample, it's a cytology, right? So we're taking cells, and the cells should be taken from this transformation zone where most commonly cancer occurs, cervical cancer occurs. So their transformation zone usually migrates inside as they become more postmenopausal. So it is like a kind of recommended test to do. So it could not be an absolute contraindication, but the methodology becomes more complicated and very difficult to say really that you're acquiring the required sample. So you may do it, but deep inside, that you're kind of not getting the right sample. Yeah.
Okay, two more questions. The first is how sensitive is low dose virtual CT colonoscopy in screening for colonic CA? And also the second question is, do we have data on the impact of HPV vaccine before and after introduction with regards to the incidence of cervical cancer in Ethiopia?
Okay. Sensitivity of CT colonography. So like I have mentioned, all the 4 or 5 cervical tests, the CT colonography and colonoscopy. All of these screening methods or methodologies have more or less similar acceptable sensitivity and specificity, more or less comparable. But what we have to know is if a client chooses to undergo CT colonography, and there is a positive result, they definitely will undergo colonoscopy. Otherwise, we give the patient advice and offer them either of these tests, and they could choose. And also, the frequency varies, right? If we use colonoscopy, then it's going to be 10 years. If we use CT colonography, it's going to be every 5 years. If we use the occult tests, it's going to be every year or every 3 years. So the duration varies, but the sensitivity or the chance of picking up pre-invasive lesions is more or less similar. The frequency and subsequent procedure is different. So it's good enough. We can use it. HPV vaccine and its effect in Ethiopia, we are not at that stage. Like I've shown you. So vaccination is started at age 9 up to 13. Catch-up vaccination is also there. And the natural history of this human papillomavirus to give rise to precancerous lesions, and these precancerous lesions to progress to cancer is very long. And to see the effect of vaccination on reduction in incidence of cervical cancer, we may have to wait 30, 40 years. And this is the data. Most of it is more kind of extrapolation, but some of the countries have started vaccination very early on, like these Western countries. So we can see how impactful it is. But for us, it's very early to really say that it has and we have to sustain actually this vaccination to get a larger number of population, and we have to register and all these things. So I think this should also be taken into consideration.
Okay, thank you. So one question that few of the audience are asking is there any indication to screen with mammography for young women? For example, below 40 years of age, like 25, 30 years. That's the question. The other is any pediatric cancers that require screening?
Okay. Age, younger age women screening with mammography, yes, because we've said that there is risk stratification, right? So there is moderate average risk and there is high risk. For example, if a person has a family history of a woman, like a sister or a mother, who acquired breast cancer age 40, then that person should start screening 10 years younger at 30. So screening will be mammogram. So of course there is this indication, but we need to use the risk stratification. Screening for pediatric cancer, I think Dr. Tensai, you're the right person. I haven't come across, to be frank, but yeah, this could be one assignment for me, but you could also comment.
Yeah, so like we are seeing that especially for hematologic malignancies. I don't know if it's because the referrals are increasing or not, but we are seeing large incidences each year, maybe with an increased awareness among health professionals as well as the public. But since the Ethiopian population is a very young population, I mean, our mean age for Ethiopia is 19 years. The average Ethiopian is 19 years. So this is one of the things that will definitely come up as the screening programs get wider. So if there are no more burning questions, Dr. Fuzum, shall we wrap up?
I think we have one guest or attendee, Dr. Takala Woldetsadik, who raised his hand. You can talk and ask your question. I think that will be the final one since we've taken a lot of time. And before we finish, I'll tell you some things about Yetenaweg and how you can join as a volunteer. And I'll send you also the link how to, I just sent you the link at the bottom. If you want to take part in Yetenaweg's different activities, you can tell us what you do. I'll talk about that in detail after the question. So Dr. Takala, the floor is yours.
Thank you for your nice presentation, Yetenaweg and Dr. Edom. Generally, we are a resource limited nations. For screening method, what do you recommend in prevention methods? Thank you.
Yeah, thank you, Dr. Takala. So, like you said, yeah, for long we've been saying that we have limited resource to conduct or to implement screening programs. Yeah, currently we're saying, we should start screening for some of, the most prevalent cancers like cervical cancer. That's well and good that is in place, but also we are advocating for breast cancer screening because we see a lot of mothers and women coming with very advanced cancers. But for prevention, it's very doable. Like we have already mentioned in the beginning of the talk. Prevention doesn't mean that 100% prevention. We can't 100% prevent cancer, but we can focus on cancer types for which we know causative factors contribute major role, like cervical cancer, HPV, breast cancer. We know most of the causes, but we can't really prevent breast cancer, for example. But we can educate women to present earlier. We can advocate about breast health. Lung cancer, we can aware people about smoking and exposure and others. But all in all, whether we like it or not, we have to implement some screening programs in the country as the professionals, the service, the health system is getting stronger. So we still cannot go on saying that we cannot implement screening programs, but we have to start somewhere. And I think personally, the time is now. Yeah, thank you.
Thank you so much again, Dr. Edom. This was an excellent presentation. I know you should be very busy with being head of the department and also teaching students and giving you Saturday to give us this excellent lecture. I thank you on behalf of Yetenaweg and also Ethiopian Medical Association. I see Yetenet from Ethiopian Medical Association is also here. If you want to say some words, you can definitely do any time. And I also like to thank our attendees. We have a large attendance today, more than 110 people were there at one point. So make sure that to check your emails. We'll send you monthly to for the next CME sessions. I'm copying, pasting again the form for, I just posted on the chat link to get your CEU credits. Anyone who attended these credits will get 2 continuous education units from Ethiopian Medical Association. But you must understand that there are more than 110 people who needs to be typed and put in a certificate. So give us at least a couple of weeks before you come back and ask for the CEUs, but we'll definitely send it to you as long as you have registered on the link that I have just posted. And I think with this, we'll conclude the talk, but I will give a few minutes about Yetenaweg. Dr. Edom, if you want to stay, that's you absolutely can, but we have concluded the talk.
Thank you so much, Dr. Fitsum. Thank you for having me, for giving me all the kind introductions, and for everyone for attending and very kind words. I hope to join Yetenaweg in the future. I'm really interested and happy with what you are doing, and thank you for inviting me to be part of this event.
Thank you so much. We'll be very honored to have you with us, and I'll make sure that I'll communicate with you through email, and we'll definitely have a lot of work to do together. Thank you. For the attendees here, I just want to share you some things here about Yetenaweg. Let's start from here.
Hello, Dr. Fitsum. I am Yetenaweg.
Hi, Yetenaweg.
Please,
please say.
Thank Dr. Edom for her nice presentation and for her attendance. I'm very happy to have her because she's serving the community as well as the medical association. She is always available whenever we invite her. I'm very grateful for that. Thank you very much, Dr. Edom. I also get a chance to visit the cancer center, and I have seen how they are serving the community. Really, it is very interesting, and I don't know how they create such culture. They are serving with special manner. I'm very happy to see that in our hospital. Thank you, Dr. Edom and your team. Also for the participants, we will share the certificate after some time. Please wait, but be sure that you wrote your email appropriately and your name completely. Some of the participants wrote their professions and their name, and when the certificate automatically prepared, they will ask how it happened, because we use this automatically from Excel sheet to we transport from the Excel sheet to the certificate. So that please write your name completely and your email appropriately. Thank you, Dr. Fitsum.
Thank you, Yetenaweg. Again, thank you, Japan Medical Association and Yetenaweg particularly for continuing to make sure these CME sessions happens regularly every month. And like Yetenaweg said, make sure you write your name, your title, and your email correctly. Otherwise, there's no way for us to reach out to you and make sure to correct it again. So that's the form that I sent you. So just a few words about Yetenaweg. It's not a motivational speaker, I can assure you that. It's just a video that I found. So we just volunteer network of what is Yetenaweg in general. Yetenaweg is a digital platform. We don't have an office. It's professionals meeting online through computer, internet, different social media platforms to create something in the health sector. So everyone that you see in Yetenaweg, they're spending their time or resources out of their time. This is not some funded organization. It's just like you, healthcare professionals and other professionals as well, working together to create something. Our main goal was to create evidence-based health information, particularly what is provided to the public. What you see in the social media everywhere is, there's a lot of misinformation. So we started initially to target that and create something that can be reliable, both for health professional and the public. And after that time, what we have found is that we also need to support health professionals as well. Those of us who have gone far in our profession, reach to the level of a specialty and more, can kind of mentor the young upcoming health professionals. So there are different things that we're working on. So we work on health promotion and work with health officials to advocate on certain health policies. We have a mentorship platform, and also we have the CME session. As of now, we have made it a registered organization. It's registered in Pennsylvania, in the USA, so that we can officially collaborate with other organizations. But we also work, like you've seen today, with Ethiopian Medical Association, with Ethiopian Medical Students Association. We just signed up a memorandum of understanding with the Ethiopian Cardiac Society, just to continue this kind of educations. How we engage and how we conduct these things is like through webinar, for example. We do CME sessions through a webinar. We do health promotion through podcasts, clubhouse discussions. We bring health professionals to come and discuss about their specialty. And also we bring health officials to come and discuss about certain policy topics. A week before, we've been talking about the quality of Ethiopian medical education. We brought people from Ministry of Health and other people to discuss the gaps in the quality of medical education. So we have different types of areas where you can engage. And if you check yetenaweg.com, it's the one at the bottom, you can see different resources. We have created a sort of a digital library with Ethiopian Medical Students Association, where we pay for the digital space, and Ethiopian Medical Students Association creates a certain books, resources for different types of things where you can access it. If you register and fill the form, they will let you get access to the library. You can sign up for the mentorship program. So check the website and you'll find different resources there. So what are the things that we look for volunteer participants? It's volunteer based. Everyone can take part. We want your leadership. We want you to take and be responsible for the project that you take. So after some time, based on your performance and other things, we can also provide you certificates of recognition for your work. And this is also an opportunity for you to network with other professionals, your colleagues. So take this opportunity to join. This just highlights areas of our engagement. And like I said, we do health promotion, generally through either writing articles that can be accessed by the public. For example, if you check American Diabetic Association, they have excellent resources for diabetes. Anyone who has diabetes can go there and check. But if we want this kind of resources, where we're going to find it? So we need to create a sort of a digital library about any health issues that is written and curated by health professionals, and the public can participate. And then we have community engagements where we do blood drives once a year. We're working with certain organizations to improve inclusiveness, especially for disabled people. And we have mentorship program. If you sign up, you get a direct mentorship from a senior about your future career paths, what you want to do. We also provide some soft skill training like communication skills, leadership skills, and some of the videos are already uploaded on our YouTube channel, so you can see like our leadership trainings or communication trainings already there. Medical education, we do the CME sessions once a month. Later this year, we'll be starting research and QY projects, where we are hoping to get a grant so that we can give all that money to the people who win the research and QY projects, so that they can conduct some quality improvement project in their hospital or in their clinic or wherever they're working. So we'll let you know more when we get there. So I will copy, paste, and share the sign up form. I have already shared it in the chat group. So if you want to join our group, please sign up, and there are department leaders. They will review your application and will reach out to you once that is done, okay? Yes, someone has shared it already there. So if you have any questions about Yetenaweg, if you raise your hand, you can ask me now, or just sign up on the forum, and I'll look forward to see you join our group and work with us. All right, again, thank you very much. Anyone can join. It's not only limited to health professionals. If you're a nurse, public health officers, everybody can join. I think the health sector has a lot of demands. So it's not only physicians group, it's a healthcare professionals group, but we also need information technology professionals, graphic designers, because there are people who are maintaining our website. There are people who are maintaining, who create posters and everything for us. Those are not health professionals, but people with designing skills and IT skills. Please fill out the form. It's hard for us to copy the email from the chat box. Just fill out the form. It has a lot of questions, and then we'll go from there. Thank you very much again. I appreciate your attendance. Have a wonderful weekend.